Hi, everybody. It's Mrs. Bartels. I'm going to do the Chapter 20 lecture for you. If you're in class, you'll get this on Monday, tomorrow, January 11th. If you are not in class, you'll have to listen to a tape lecture. And then Tuesday, we'll do Chapter 21. And Wednesday, you will have a quiz on 20 and 21 to do online. Okay. So I'm in my morning class, as you can see. I'm going to hop on over to materials. Okay, and if you go down to, and everybody's might be set up a little bit different. Miss Betty Jo, Miss Chrissy might have something that looks a little different, but it's still the same. You're going to go to your Module 3 folder. So you're going to find Module 3, whoever's class you're in, and you want to find Chapter 20 and 21. So here it is here for my kids. I believe it's orange for everybody's class. You click on it. You'll see you have your PowerPoint for 20, your PowerPoint for 21. Your homework assignments are in here. And your daily assignments are in here. When I'm done recording, I will drop the tape lectured into here under the Monday daily assignment. Okay, so I'm going to scoot on over to PowerPoints that I have open in a different screen. Okay, we're going to start with Chapter 20. So Chapter 20 and 21 is about urination, or urinary needs of a person, and catheters. 21 is about the catheters. So first we're going to talk about urinary needs. Okay, so here are, so I'm going to go over here really quick. Just change the screen a little bit for you guys. Okay, so beginning of your PowerPoints. Here we go. These are key goals of the lesson goals or targets that you want to know. And then we're going to start with slide number 1. Normal urination. We're going to talk about the normal stuff. Then we're going to talk about what happens when somebody can't urinate the right way. Abnormal urination or incontinence. Okay, the urinary system. So our system that consists of our kidneys, our ureter, our bladder, and the exit to release urine, that is our urine system. The goal or the whole target of the urine system is they remove the waste products from the blood. So basically what happens is your body circulates everything through its blood, and then what the body does not soak up, it kind of dumps into the kidney, and then the kidney decides, yes, this is worth keeping, and it might filtrate it back out because the kidneys are like a filter. Might push it back out to the body and say, hey, you made a mistake, you want to use this. But if it's something that the kidney knows isn't good for the body, it's going to push it down and make it into waste, or what we call urine. Okay. The other thing the urinary system does, it maintains our body water balance. So basically our urine system gets rid of waste that shouldn't be in our body and makes it into urine. And it maintains our balance of water. The word urination, also known as voiding, and you'll hear voiding a lot. So know when we say void, the patient needs to void, or the patient was voiding, that means the patient's urinating, or they need to urinate. Okay, so void means urinate, voiding means urination. So when someone is doing the process of urination or voiding, it means they are letting urine out from the bladder. They are peeing. Okay, they are going to the bathroom. So someone says they need to urinate, they need to get to the bathroom. Someone says they have to void, they have to get to the bathroom. Okay, and the process of doing is called urination or voiding. A normal healthy adult will produce about 1,500 mLs of urine a day, which is like 1.5 liters or 3 pints. Make sure you know the 1,500. That is normal. Okay, it says normally somebody will get rid of 1,500 mLs. Okay. The way that a person urinates can be affected by the following things: age, perspiration, drugs. So let me move this out of your way, guys. The amount and kind of fluid that they're ingesting, their body temperature, their dietary salt intake, and any diseases they may have. So, talking about that really quick, things that affect the urine production. I have to sneeze. I'm sorry. Excuse me. Excuse me. I'm so sorry. I'm sorry again. Okay. Sorry. So age. As we age, everything in our body begins to slow down and not work as fast, and that includes our kidneys. So as we age, we might produce less urine than when somebody who's in their mid 20s or 30s and has active kidneys. So age can affect. Also, when we're younger, our bladder is smaller. Like toddlers have a smaller bladder than somebody who's 30 or 40 years old, so they can't hold as much urine. So like a toddler may have to go to the bathroom more often because they don't hold a lot of urine. Perspiration, well, if we sweat a lot, that means we're getting rid of fluid. That can affect our urine. Drugs, there are all different kinds of drugs that affect the urine. Prescription drugs. I do home health, so I take care of people that have heart failure, and I teach them about how to balance the fluids so their heart that's barely, when you have heart failure, your heart is already having a hard time working. So we have to teach them how to be careful about their fluid intake and make sure that the urine is a good amount and equal. So we really have to teach them a lot about intake and output. People that are on heart failure medications are usually on a water pill. Water pills is a type of drug or medicine. They're called diuretics that make a person urinate more than usual. They help pull off the water because the heart is weak and it can't do it. So there's an example of drugs for you. The amount and kinds of fluid ingested. Caffeinated products, Coke, coffee, tea, can affect the bladder, and they can actually decrease the amount of output that a person has. So caffeine is not really good for your bladder. Neither is nicotine if you're a smoker. So those things can affect your bladder and decrease your urine outputs. But things that are great that help increase urine output and increase people to urinate is plenty of water. IV fluids helps. Cranberry juice is good for the bladder. So things like that. Dietary salt, of course, if you have a high salt intake, we learned that in the last chapter. If we have a large amount of sodium, our cells will swell and then we'll keep fluid inside us. We retain fluid. So if you're having a large amount of sodium or salt in your diet, your urine might be a lower amount coming out. Okay, and then diseases, they're talking about like heart disease, kidney disease, bladder cancer, kidney cancer. Those can all affect the amount of urine somebody has. Okay, so moving on to the next thing. Okay, when a person's urinating, you have to take a look at it. I know you're thinking, I don't want to look at people's urine, Mrs. Vartalis, but you have to. Okay, you have to look for things that you need the reports. First of all, on page 295 of your book, it says what normal urine is. Let me see what's on the next. No, it's not even in your slide, so let's go over it really quick. So normal urine, on page 295, it says normal urine is a pale yellow. It's straw-colored or amber-colored. It is clear and has no particles, meaning you could like see through it. Okay, and it may have a faint odor, which is normal. So a small amount of odor is normal. So let's take the sentences right there on 295 and break them up. If you look, there's a color grid on page 295, figure 20-1. It says clear, yellow, and amber. Those are the normal colors of urine. Okay, so urine, even looking at this little guy here, our raindrop, if you don't want to open it, or your urine drop. This is like clear. Okay, this is what I would say yellow, and he is amber. He's got that orange glow to him. Okay, so anything that looks like lemonade to apple juice is considered a normal color for urine. Okay, however, if the urine starts to look like a nice tea color or any red in it, that's not normal. You need to let the nurse know. So when I'm a urology nurse, so that's my specialty. So when I worked in urology for years, we used to always tell people it's hard to understand what yellow and clear and amber is. So we'd say if your urine, it looks like lemonade or apple juice, you're okay. If your urine looks like iced tea or Merlot wine or cherry Kool-Aid, you need to call the doctor. So those are good ways to kind of think about the color. Odor, it is normal to have a little bit of odor. If it has a very strong odor or like an ammonia odor, and I always think of like cat litter because cats do have a strong, if the litter box doesn't change, that strong odor. If you're smelling that when you're changing your patient, something's wrong. You need to let the nurse know. You should not be taken back by the smell of their urine. Okay, so if you're taking them to the bathroom or even if you're changing their incontinence breath and you have very strong odor and you're like, oh, that's purulent, that's awful, you need to let the nurse know. It should just be a faint odor. Okay. And then urine should be clear. You shouldn't hold it up and see like cloudy stuff floating in it. So you shouldn't see like little dead tissues or pieces of like, I don't know, skin that looks like, or like tissue floating in there, or any blood. You shouldn't have anything cloudy or clumpy in there. It should be clear. So that is a good description of urine. It is not in your PowerPoints. It is on in your book on 295 though. And there are questions about that. Okay. Problems with urinating. These are in the PowerPoint and in your book. Dysuria. So again, dys means difficulty. DYS means difficulty. Uria is urination. So somebody has a hard time or painful urination. Hema means blood. Uria means urine. So it's blood in the urine. NOC, N-O-C, means nighttime. So uria, that means they're frequently urinating at night. Ali means scant. This is where we did our vocabulary for chapter 6 and 7. Those terms that we did, the prefixes and suffixes and roots, here they are, guys. So Ali means scant, and uria means urine. So they have a small amount or very scant amount of urine. Okay, it's like they have to go to the bathroom and they get up and it's just like dribbles, and they're not going good amounts at all. Poly means many. So, and urea means urine again. So this is when they have a huge amount of urine. We might say they're peeing like a racehorse. Okay, they're peeing big amounts like a horse or like a larger animal. Okay, urinary frequency and urinary urgency, these should get confused a lot. So when somebody has frequency, it means they have to go often. Okay, it's like, we just went to the bathroom, we're going again. Okay, we're going at, like, they're going every hour, or they might be going every 15, 20 minutes. That's frequency. Okay, urgency means they need to go when they got to go. Okay, there's a difference. Frequencies, they're going multiple times. Okay, urgency means they have to go when they got to go. Don't get them confused, guys. All righty. And usually somebody has frequency, they have urgency. But again, frequency is they have to get up. Frequency is I need to go. It's 12 o'clock. I need to go to the bathroom, and then they're going to call it again at 12:10. I'm like, you just went to the bathroom. We're going again. Okay. Then it's 12:30. They're going again. They're going at frequent time. They're going frequently. Urgency means I got to go. I got to go right now. If you don't get here, I'm going to have an accident. Okay. Okay. Then we're going to talk about the supplies that we use to help people urinate. So people can urinate, of course, in the toilet like you and I do. But if they can't get to the toilet, they might have to use a bedpan. So there's two types of bedpans in the pictures here. The one is a standard bedpan. It's the big fat one that kind of looks like I say it looks like a donut, kind of like the big and round. And then there's a fracture pan that reminds me of like a wedge, like a doorstop. Okay. So there's a standard one here, and then there's a fracture pan. People that use bedpans are people who cannot get out of bed. They are bedridden. They can't get up and go on a commode, which is a portable potty. They can't get up and walk to the bathroom. For some reason, they're not allowed out of bed. But they know they have to go, and they don't want to have an accident, and they don't want to be incontinent. So we give them a bedpan. Okay. Women use them for voiding and bowel movements. So women use them to urinate or have bowel movement. Okay. If I'm bedridden and I have to urinate, you're going to need a bedpan. If I have to have bowel movement, you're going to need a bedpan because I cannot get out of bed. Men only use bedpans to have bowel movements. They use a urinal to urinate in, which is coming up in a couple of slides. Okay, so ladies will urinate and have bowel movements in bedpans. Men will just use it for bowel movements. The difference between them, this big one can be used for anybody. Okay, but if somebody has like a cast on their leg, or they might be in traction because they have some kind of orthopedic thing going on, and they're not able to move side to side and bend well, we're going to use the smaller one. If they have limited back motion, if they had any kind of spinal cord injury, if they had hip or knee surgery, we're going to use, and they cannot get out of bed and they have to use a bedpan, this is the bedpan you use. Okay, so the fracture pans are more for people that have like cast traction or some kind of surgery related to their bones or orthopedic surgery. You're going to give them a fracture pan. And when you put a person in a standard bedpan, their butt sits on this part here, and this is the front. Okay, when you put somebody on a fracture bedpan, their butt is on the smaller part, and this is the front where you can grab the handle and pull it out. Okay, so again, for a standard bedpan, the butt sits here, and this is the front of the pan. It's different for the fresher pan. This is the back where the butt sits, and this is the front of the pan. So when you open up your person's legs, you'll see this part of the bedpan. When you open your person's legs, you'll see this part of the bedpan. Okay, look in the book for pictures if you don't understand that, you guys. There's a good picture to do that on page 298. It shows you how to place standard bedpan. You can see the big part goes against the buttocks. The smaller part is lower on the body, and then it shows a person sitting on the bedpan on page 298. Okay. Men. So men, in order to urinate or void, remember the word void means urinate, they use a urinal. The man stands if possible. When you think about it, if a man is going to urinate, he stands over a toilet. So if we're going to give him a urinal or a jug, it looks like a jug, to pee in, and he naturally all his life has stood up to pee, why would we not try to stand up and let him use the urinal? So they like to sit up or stand up and use it. If they cannot stand up, they're not strong enough, they might sit on the side of the bed and kind of hang the urinal down. Okay. It's very difficult, excuse me, oh my gosh, for a man to pee lying down. All their life, they've stood up. So helping the man stand up to use the urinal might be necessary, or maybe having them sit on the edge of the bed where like in a sitting position would be easier for them. It's very difficult for them to pee lying down. Sometimes you might have to place the urinal and hold the urinal for the man, meaning their hands are shaking. Maybe they have Parkinson's disease. Maybe they have dementia. Maybe they're just not strong enough to hold the urinal in place. So you might have to take and help them put their penis into the opening of the urinal and hold the urinal while they pee. Okay. If they're able to do it on their own, you just, once it's placed, you give them some privacy. And when they're done, you tell them to put the cap. There's a cap. You could see it hanging down here. This is a cap. You tell them when you're all done, cap it and hang your urinal on the bed rail and place the call light so I can come in and answer the call light and empty the urinal. Make sure they do not place their urinals on overbed tables. It's the tables that we use to for our supplies, or they use it to eat off of. And make sure you don't let them put it on the bedside stands. The urinal has to be hung. See this little handle here? It slides right over the side rail. Urinals should be hung on the side rail. They should not be put on overbed tables or bedside stands. That is a state test question each year too. If the person doesn't have a bed rail, maybe they don't have side rails, then you have to do what the facility says. Okay? There are female urinals. I have not seen one in many years, so I'm not going to talk to you guys about those. They are just, the opening is shaped differently. Okay? There's a picture of a urinal on page 298 of your book. And the second paragraph underneath urinals talks about after voiding, he closes the urinal cap. And it goes on to say what you tell him to do with it. Make sure you know that. And I did say it already. Commodes. So commodes are like porta potties or portable chairs. They're like a little portable toilet. Commodes are used for people who cannot ambulate to the bathroom. So maybe they can get out of bed, but they can only go a few feet. They really have a hard time getting to the bathroom. Or maybe they're having frequent urine and diarrhea problems, and it's just easier because you don't have an accident. They go to the commode. The commode sits at the bedside, usually. Commodes can also, there's a bucket. So here, I'm going to go over them with you really quick. There's a frame, there's a toilet seat, and there's a bucket. So it looks very much like a toilet. The difference is it has this frame to help have the person hold on to. So there's like bars for them to hold on to. So they sit on it just like a toilet, okay? And then because there is no plumbing attached to it, everything goes into the bucket. The bucket slides out and you empty the bucket, clean it, disinfect it, put it back in. Then you clean the tops and the seat and everything, and you close the lid and it stays at the bedside. Another thing that can be done with commodes is this bucket, like I said, slides out. So we could sit this commode over a toilet So maybe the person can get into the bathroom, and in order for it to be more normal urinating or bowel movements for them, we're going to put this commode over a toilet because the commodes sit higher. And again, they offer support. The person's able to hold on to the railings, the sides, the armrest. So sometimes we'll put this over a toilet to help a person sit on the toilet, but so they have more support and it sits up higher. Because toilets are low and people that have hip and knee problems might have a hard time getting on a toilet. But if we put a commode over it, that makes the toilet higher and it's easy for them to sit on. Okay, so now let's talk about the slides here. A commode is a chair or wheelchair with an opening for a container. So again, it's a toilet or a chair that has an opening for the container. Persons who are unable to walk to the bathroom often use commodes. It can be placed near the bed. Some commodes will have wheels and are wheeled into the bathroom. So maybe I get my person out of bed, I sit them on the commode, okay, and the commode has wheels. Now I can wheel them into the bathroom over the toilet and they can have their bowel movement or their urination there, okay? If it has wheels, of course, you have to make sure it's locked. When they are done, we are going to clean. If they urinate or defecate into the bucket, you're going to clean the bucket. If it's over the toilets, then you are going to put them back to bed and you're going to clean it and leave it at the bedside. Okay. One important thing I will say about commodes is on page 300, it talks about promoting safety and comfort. You will transfer the person to and from the commode. Practice safe transfer procedures. Use the transfer belts and lock the wheels. Make sure the person has shoes on. Remove the transfer belt once they're on the toilet. So if somebody's going to use the commode, you're going to have to do a transfer, which means you're going to take them from the bed, make sure they're wearing shoes, put a gate belt or a transfer belt around them, stand them up, get them from the bed to the commode. And then once they're on the commode, you're going to remove that gate belt so they could urinate or have their bowel movement. You're going to provide for privacy. You want to pull this curtain and make sure they have the call light and tell them to call when they think they're done. You could also put a blanket or a sheet over their lap so they have more privacy and they're covered and they're warm. Okay, so that is all on page 300 in the green box about comfort and safety. And that takes care of commodes. On page 301, I did highlight in my book number 23, 24, 25, and 26. There is a question about what to do after a person's done using the commode. Number 23, you empty the contents into the toilet and flush. You rinse the container, pour the rinse into the toilet and flush. Clean and disinfect the container. Pour disinfectant into the toilet and flush. Dry the container with clean, dry paper towels and return the container to the commode. Close the lid, clean the other parts of the commode if necessary. So make sure you know how to take care of a commode after a person uses it. Okay, next slide. Urinary incontinence. Incontinence, okay, is the involuntary loss or leakage of urine. The most important word in here is involuntary. Nobody wants to pee their pants. Nobody wants to be incontinent. Nobody does it on purpose. You have to understand that. It's embarrassing and people do not like to do it. It's not like they're doing it on purpose. And saying they had an accident, that's not true. They didn't have an accident because it's involuntary, okay? They don't have control of their bladder any longer. There's different types that we're going to talk about down here. They might not have the urge. They might not feel that they have to go. They might not know that they're full. Okay, it's something's not connecting to the brain to tell them they have to go. Okay, and there's all different things that can happen. We'll talk about that later. So make sure you understand it's involuntary. The person does not do it on purpose. They are embarrassed and it's not a pleasant thing. And again, if they're incontinent, you need to really step it up and understand it is not their fault. It is something that happens with their body and you need to make sure you're giving them good care. It can be temporary or it could be permanent. I'm going to scoot to the next slide just to see if she has more in here. Okay. Kind of. Okay. So I will say, if you look at managing incontinence, which is on page 302, I'm going to read what it says in your book, and I already said it to you. Incontinence is embarrassing. Garments get wet and odors develop. So now the person's sitting in something wet with urine and odor develops. That is embarrassing and is not anything that anybody wants to have. The person is uncomfortable. The skin irritation, infection, and pressure injuries are at risk. If they're sitting in urine, remember what we said in the beginning of the slide, urine is waste. So basically, if they're sitting in urine, they're sitting in garbage or waste, and that could eat away at their skin or cause infection or cause pressure sores. Okay. Another big risk with incontinence is falling. They want to get to the bathroom, so they try to get up to the bathroom by themselves, and they're at risk of falling, and sometimes they fall. Okay, so falling is a big thing, and their self-esteem is definitely affected. Their pride and dignity is affected. Okay, sometimes they social isolate. They'll lose their sense of independence. They can get depressed, and they can be angry. You have to understand nobody wants to have this go on with their body. Okay, so it could be very trying for you. You may be like, I just took him to the bathroom and he's dirty again. If you start to feel impatience or aggravated with your patients, you have to understand they're not doing it on purpose. They're probably just as aggravated and just as embarrassed and just as frustrated as you are. Talk to your nurse. You might need a break. You might have to switch out the assignments a little bit. Okay, so please remember that. I think it's very important. As a urology nurse, I could tell you urine really does affect how a person feels about themselves. Okay, we're going to talk about different types of incontinence. Stress incontinence. Stress incontinence happens when the urine leaks out from the bladder. It usually is because of something going on, like some kind of stressful thing, like maybe somebody's doing aerobic exercises and they're jumping up and down, or they're like, I don't know, in a trampoline and they pee a little bit. It might be they sneeze too heavy and they pee. It might be they laugh too hard or they cough too hard. Okay, and they have stress incontinence. So like every time somebody sneezes, they have a wet episode. That could be stress incontinence. If they cough too hard, if they vomit or throw up, and the force of the vomit makes them urinate, that's stress incontinence. Okay, and one time, 2 times isn't a big deal, but if it's happening every single time, then it's considered stress incontinence. Overflow incontinence is when the bladder is so full that it leaks a little bit. Okay, and I always tell you guys to think about a pot of water. So say you're going to make macaroni, and you take the pot and you put it in a sink and you fill it up with water, but then you get distracted and you walk away, and now that pot is overflowing because you still have it underneath the water and it's still filling up. It fills all the way to the top, and now the water starts flowing out because it's full. That's what overflow incontinence is. The bladder gets filled, and because a person doesn't empty their bladder, when the body creates more urine, the urine starts to flow out. So we have a little bit, you have like an overflow. Functional incontinence is when the person has control of their bladder. They know they got to go, but they can't get to the toilet in time. Okay, this could be like maybe somebody has a broken leg and they know they got to go to the bathroom, but they just can't get there in time, so they have an accident. Okay, and they're incontinence. Another one could be maybe somebody had a stroke and they know they feel the urge that they have to go to the bathroom, but they just have a hard time doing the transfer and getting to the bathroom in time. So that's functional incontinence. Sorry. There's other incontinences that are in your book, but the stress, incontinence, overflow, and functional are ones that you definitely need to know. Okay. I would definitely say those. Those are the 3 common ones. There are other ones in your book, but I wouldn't say you have to know those. So what can we do for these people that are incontinence? Well, we have to answer their call lights promptly, and we need to check them often. Okay, because if they are able to tell that they have to go to the bathroom and they're putting the call light on, you need to get in there and get to them so they go, so you can get them to the bathroom. But sometimes they can't even tell they have to go. So it doesn't always work answering the call lights. You also have to check them often, okay, and offer them to go to the bathroom. You can encourage pelvic exercises. They're called Kegel exercises. Make sure if they are incontinent, you are checking them often and making sure they are dry and you are giving good skin care, looking for the redness, looking for the irritation, looking for skin breakdown, providing them with the best skin care possible, giving good peri-care, moisturizing their skin. Use the incontinent products that the nurse tells you to use. So they have to put a brief on. Don't call them diapers. They have to wear an incontinence pad or a brief. That will be on the care plan, and a nurse will tell you which one to use and how to use it. Make sure you change them as soon as they're wet. And that includes not just their brief or their pad. If their bed is wet, change their bed. If their clothes are wet, change their clothes. We already talked about the risk: skin irritation, infection, pressure injuries, and I said why. Falling is a risk because they're trying to get up to go to the bathroom, so they don't have an episode of incontinence. And we talked about dignity and self-esteem earlier. Okay. Here's different incontinence products. You could see this is like a pull-up brief. This is a pad, and this is like a brief. I hate to say it's like an adult diaper, but we don't use the word diaper. Please don't use that. It's very derogatory, and it's not allowed. You should say incontinence brief or pad, but don't use diaper. Okay. And just know this: you always remove from the front to back. Just like when we're doing pericare, we go front to back. So this is dirty, and I'm going to remove it. I'm going to remove the front to the back, just like when I wipe somebody when they're dirty, front to back. Okay, make sure you know that for your tests. Bladder training. Before we go to bladder training, I'm going to talk to you on page 393 of your, or I'm sorry, 303 of your book. Make sure you read the orange box about the focus on older persons. Know that persons with dementia may void in the wrong places. They don't understand. They don't remember what a toilet is. So they might void in a trash can. They might go into plants. They might go into heating vents. They might go in closets thinking they were bathrooms. Some of them will throw their incontinence products on the floor or in the toilet, not realizing they shouldn't have done that. Others may resist being clean because they don't understand that they're dirty. Okay. And then it gives you bullet points on what you should do for a person with dementia. Page 303. It's on your test. Read the orange box. Okay. Then applying incontinence products. We did on page 304. Page 305 in your book. No, you did a procedure, and I talked to you about this already, that you remove it from the front to the back, number 17. And I would also know 13 and 14. 13 says you're going to cover the person with a bath blanket when you're changing them. Of course, you're going to have privacy. You're going to put a pad underneath them, and you're going to remove the dirty brief from the front to the back. And that's also in the green box under providing safety and comfort, page 305. Okay. Bladder training. So if somebody's incontinent and we want to try to get them back to maybe being continent or not having to be so incontinent, we want to try to train the bladder to work again. The goal of bladder training is to help the person with urinary incontinence, try to get them to stop being incontinent or maybe decrease their episodes of incontinence. Okay. The goal is control the urination, get ahead of it. How can we beat it out so they're not having accidents? Okay. And it's different for each person. Bladder training is very personalized. You have to the nurse and the doctor it's usually a urologist doctor and a urology nurse will sit down and kind of make a log, have the patient make a log of when they're having their episodes of incontinence and what they're eating, what they're drinking. And then they kind of make a schedule for that person. Like say, Mrs. Adams seems like she's always incontinent after breakfast, lunch, and dinner. And then she's incontinent at bedtime. Well, now we know that she needs to be toileted before meals and definitely right after meals. Because it seems like even though they're toileting her before the meal, she's going to the bathroom right after her meals. So she'd be the kind of person, her bladder training program would say, toilet her before meals, have her eat, and toilet her immediately after meals. And then same thing before bedtime, we would make sure that we toilet her. Okay, so that would be her plan. Everybody has different training plans depending on what their characteristics are and when they're having their incontinence. But again, the goal is to control that urination. If they have a catheter in place, catheters will make a person's bladder lazy. So when a catheter is in, the person doesn't have to do any work. The urine just flows down naturally. So if we're going to try to get somebody to get their catheter out, and we want them to start urinating normally when that catheter's out, we might have to do some bladder training before we take the catheter out. So what happens is the person has the catheter in, and the doctor will order a certain time and a certain time of day and a certain amount of time that he wants us to clamp the bladder or clamp the catheter. Okay. That's how we do bladder training with a catheter. We don't take the catheter out. If we know that a person has a catheter and we want to try to get them take that in a couple of days, we're going to take the catheter out. We want to make sure they're able to pee normally. What we do is we start clamping it. And what happens is the catheter is clamped. and there's a picture of it on page 307 in your book. It's kind of like pushed and shut down, the tube of it, for about an hour. Okay, and then we open it up and the person will feel the urge to pee because we clamped it. Okay, and then we'll clamp it again, maybe next time for 2 hours, and we'll open it up and the person feels the urge to pee. So they're starting to get that feeling back, because with a catheter in all the time, they don't have the feeling they have to pee, because the catheter just does the peeing. So if we're going to get ready for them to get that feeling and train them again, we clamp it. Okay, so it gets clamped, and then a doctor might say clamp for an hour, and the next time it'd be clamp for 2 hours, then 3 hours, then 4 hours. And then once we know the patient's tolerating the clamping, we will tell the doctor, and the doctor will tell the nurse, go ahead and take the catheter out. Okay, so that is catheter clamping. It is on your test. Make sure you understand it. So again, if the person has a catheter in place, you'll see on page 307, there's a picture. There's a clamp that they put, and it squeezes the catheter shut, the tube of the catheter, so the urine stays inside the person. And then when we let the clamp off, the urine flows again, and the person feels the urge to urinate. Okay, so that's catheter clamping. Habit training was the other one that I talked to you about, where we do scheduling. So like I said, Mrs. Adams, she has to pee all the time. It seems like after each meal, she's having incontinence episodes immediately. So we have to make sure her habit training is we're going to toilet her right after she eats. Okay. Usually with habit training, we're taking them to the bathroom every 2 or 4 hours too. And how would you know your person on bladder training? Not everybody gets it. So you'd have to check your care plan, and there'll be a specific, it will say like bladder training. And then underneath that will have specific things of what you need to do. Like with Mrs. Adams, I was talking about, it would say toilet her immediately after each meal. Okay. It might say toilet every 2 hours for somebody else. So you have to read your care plans. And like I said, not everybody's on bladder training, or talk to your nurse. And we're done. That's it, guys. All right, I think that would be it. I would look at the pictures that I pointed out in the lecture, and then we'll do chapter 21 tomorrow. Have a good night. Bye.